pandemic, as well as other technologies. Welcome, Mr. Souheil. I'll share the screen so I can upload your presentation and you can start. Good luck.
Thank you a lot, Nadine. Could you please provide the full screen mode?
Yeah, sure. Can you see it now? Is it clear?
Can you hear me?
Yes, we can hear you. Is the screen clear to you too? Can you see your PowerPoint?
Yes,
okay,
yes.
great.
Okay. Hi, everyone. Today we will discuss a great and challenging topic, which is isolation precautions, limitation and challenges. This study has been done a couple of months before the COVID pandemic, and it's related to the nursing. Please, next. Okay, concerning the infection control strategies, we have several strategies of infection control at the hospital setting. We have the hand hygiene strategies, we have the personal protective equipment strategy, we have the antibiotic strategy, we have nosocomial infection control strategies. Among these strategies, we have the isolation precautions. As a simple definition about isolation precaution is that any patient admitted to our hospital complaining of an infectious disease, it could be contagious, we must take an isolation measure with him. Isolation measures such as isolating the patient, putting a sign, taking special consideration with him, like wearing special PPE, for example, the mask, the gown, the gloves, performing hand hygiene. These isolation precautions are taken with such patient. In that period, also we had a notice which says everyone who is admitted from another hospital, special precautions need to be taken with him. Also, if he had got a CRE, like carbapenems-resistant enterococci, or any SPL, he have to be in isolation until further declaration. Also, we have the emergence of the multi-drug resistant organism. We have seen a lot of patients complaining of MDRs, and that makes our topic more interesting and more challenging to be talked about. For the demographic data, 82 of nurses were between 20 and 30 years old. 84% came from institutes, and 84% are registered nurses. Next, please. Okay, there are several limitations we discussed in the study, and I will tell you the actions that were taken after the study. There's several limitations ranges from the orientation period. I mean, by the orientation, like when the staff enter the hospital as a new candidate. Also, another limitation, which is his knowledge. Can he have an access to standards, the monitoring programs that are running within the hospital? Does he act in a safe environment? Does the hospital provide the proper PPE without shortage? All of these limitations I will discuss everyone, and also I will discuss with you what are the challenges and what are the actions taken in progress. Please, next. Please, next. Okay, for the orientation program, you know, every nurse who is going to enter the hospital need to have an overview about the hospital program. We will take the part concerning with the infection control. At the first week, the candidate will be introduced to the infection control policy or procedures, also to the basics of infection control, like hand hygiene, PPE, isolation precautions, what to do in case of he had a needle stick, what are the steps taken to disinfect a certain room or isolation room. These topics are introduced to the staff. In our study, 90% of these staff are introduced to the orientation program. The other 10% were not introduced due to that the administration needs them immediately at work. They are, have a contract with another hospital. They can't afford, a little time for being oriented. So the orientation program was run into a shortcut. The head nurse will provide this program, and the staff will continue his work. The orientation program will be just 5 to 10 minutes, although the orientation program is 1 to 2 days. For this limitation, there are risky acts during the orientation program. Still, orientation program need to be just a knowledge giving. We should monitor the actions. It must be, any risky act must be supervised by the head nurse or the supervisor in the hospital. Please, next. Okay. For the knowledge checkup, we have competency tests, we have training sessions. We ask the nurses. Most of the nurses took a training session after the probation period. There are posted signs present. 87% declare there are posted signs of infection control, like do the hand hygiene at the proper moments, take PPE, don't use gloves in the corridors. These posted signs are variously present. But we have a problem at the training session. When attending a training session or listening to a PowerPoint, you will only focus during the 5 to 10 minutes. After the 10 minutes, you will be distracted by a lot of things. After the training session, no one is monitoring you. There is no knowledge check-up post-training sessions. So we did several actions in progress to maintain the knowledge of the staff. Please, next. For this, we developed this table. It is an infection control training matrix. We don't want the staff to stay for 2 hours in the orientation or in any training session, sitting in a 2 hours period, listening to the all of infection control policy on procedures. We did an infection control training matrix, which tells, for example, the administration have no relation with the isolation precautions. So they must not be introduced to this part. We tried to focus what, as a nurse, I need to know as the basics of infection control, in order to have a well-based knowledge. So we did the infection control training matrix. This training matrix preserves a lot of time for us and let others focus on specific topic need to focus on during their practice. Next, please. Also, we developed a training log which tells how many training hours do we spend on the nurses. This will let us know what are the hot topics are delivered to them, what the nurses are already get known to this topic. Are they introduced every 2-3 months, or we just give a training session at the beginning of year and then leave them till the next year? This log will tell us that we need, like hand hygiene, we will never give one hand hygiene session per year for the ICU patient. We will give it every 3 months, every 5 months, every 6 months. But what tells us we have to do it at this frequency? I will tell you what are the next actions that we took in progress. Please, next. Okay. During the training sessions, we did several points on please do hand hygiene at the following moments. Still, the nurses forget what they are doing. So we place a healthy promotion materials to focus on. For example, the use of machines are never being disinfected by the nurses. They drop them. They just take care of the patient, give their medication, take the care of every shift, but they forget disinfecting such machines. Also, the nurses, when using a stethoscope when assessing the patient, They forget to use the hand hygiene or do the hand hygiene process. So we have to put health promotion materials. We gave them training sessions, but training sessions have limitations. Is that the nurses are overwhelmed with work. We will see this in the next slides. Please, next. Also, we let them know, like disinfectant. It's not, the nurse must not act like as he living in his own home. Disinfectant has a certain contact time. He must respect it. Like, for example, when discharging an isolation patient, he must not just disinfect the room and, okay, it's ready for accepting another patient. There is a contact time. And also we let him know that this contact time will cover a bactericidal, a virucidal, a sporicidal, and that time should be respected. They should not just admit a patient, discharge a patient, admit a patient, discharge a patient. They need to know that disinfectant have real measures. They need to be considered. Please, next. Also, when talking about training, as just I said, it take about 5 to 10 minutes, and then I will not talk on that it needs 5 to 10 minutes. It will take 30 minutes. After 30 minutes, they will be distracted. We also need to push in the simulation program. Simulation programs such as Partner to Heal. This infection control program will give 5 scenarios. One as a visitor, one as a doctor, one as an infection control, one as a resident, and one as a nurse. You take, for example, the nurse, okay? And it will guide you through that every morning, what to do in case of you enter the floor, you care for an infected patient, you admit a patient for a certain isolation precautions, you need to disinfect a room. It will guide you by a simulation program. This Partner to Heal will talk as if you are in a real hospital and will let you know if you take the proper wrong decision, it will guide you to a false action, like the patient will get a nosocomial infections. So this kind of program limit the issue that training is just, memorizing for 1 or 2 days and then forget all of the things that you have learned. This simulation program reserves the knowledge for these nurses. Please, next. Okay, infection control exam. Another question arises here. Why do we want to train nursing? Why do we want to train ICU nurses every 3 months or every 6 months? If they have the proper knowledge, why they need to attend such training sessions? We did an infection control exam. This infection control exams was, for example, this one was given to the OR. If this person pass the exam, you don't need to do a training session. You just focus on the caps or the questions that they have mistakes in it, and you only take 5 to 10 minutes with the staff. So you don't need to spend 2 to 3 hours, and you don't assess after it if they have the knowledge, if they are still reserving the knowledge or not. This kind of exam, have a lot of limitation. Like anyone can enter via his phone and open the policy and procedure and able to read. I want to make sure that this person have the proper knowledge. So what we did, like for the ICU, we set a limit. Like in March 2021, we will do an exam on Monday at 3 p.m. All will attend on Monday at 3 p.m. and will run, and the exam will run to them. Everyone holding his phone and will do his exam. If they pass in the exam, no need for training session. So that reserve first the time that are consumed during your training session. Second, the staff faults. And that's why, training sessions or basic training sessions, we are doing them every 1 year or 2 years, like just to introduce if a new knowledge arises. Please, next. Okay, access to infection control policies and procedures. A lot of nurses complains that you train us, and once we are in the field, we didn't see any policies or procedures. And if we want to check on policies or procedures, we don't have time for it. So 88% have the access to policies and procedures, but they don't have the time to read them. They don't have the time to negotiate the important issues that they are facing in a daily practices, and that was a real concern. Next, please. Okay, for this, for such issues that they don't have the time for reading the policy and procedures, we developed an infection control program, and this application can be downloaded at any phone. They can enter the policy and procedure at any time during their rest periods, during their vacations, anytime they want to access the policy or procedure, they are able to do so. You know, most of the Lebanese hospitals, just tells that policy or procedures are only for hospitals, and they don't want to share such information. Unfortunately, I am against this issue. The policy on procedures are widespread. CDC and other parties distribute such as the APEC policies and procedures, and no one, it's irrational to hide them. So these policy or procedures, these are present on their smartphones. Plus, we did, other than the Google form, there is a training exam. You can enter it, do the exam, and you can have the results immediately with the gaps or the faults that you have done during it. Also, we did added several videos to this program in order to let them know that they are just not the persons that are talking about policy or procedure. There are other persons who are talking about it. Please, next. Okay, for audits, most of the time, 60%, the nurses said that there are audits running on the floor. But, you know, do they tell you about your non-conformities? 44% report rarely they do, 28% they report never. So the shift that infection control are going, or other parts, like the quality, the safety, go to the department, do the audit, and they never tell the staff about their mistakes. And that creates a real problem. They don't know the faults, where they are falling in the wrong part of doing such practices. So the feedback mechanism need to be well maintained. Also, another problem during the disinfection, no one is checking. It's just a visual audit. It's cleaned or not, and they report 80%, 90% of the department is cleaned, or 80 or 90% of the floor is of the room is cleaned. So we have a problem with the visual audit, with the aspects of audit being audited. Next, please. Okay, we have we did a tracking record for them in order to know what aspects of audit are being failed in the department. The coloring in red represent a lower non-conformities. The boxes in orange tells you that you have 90 to 95% conformity, and those boxes in green tells you that you are 100% conformity with the standard. This kind of log will trigger to the staff and all those healthcare personnel that enter to the department know that they have deficit in blood and body fluid exposure. They have deficit in isolation precautions. They have deficit in wearing PPE. They have deficit in doing hand hygiene. This kind of log, you don't have to buy it. It's just an Excel sheet, but it's a friendly version. And you can see the upside and down of the departments. Like one get 80%, the other gets 70%. That create a great competition between departments. that they need to achieve the minimum acceptable level of conformity, which is 85%, as we said previously. Next, please. Also, we did a waste segregation campaign. Let me take an example. The ICU, it was 63% before any actions. One action is taken. You don't have to put posters and do educational sessions and a lot of things. Just one action. We send a memo that they need to think yellow. Waste segregation, medical waste, put the medical waste in the yellow bag. That's all what we need you to do. Okay, think yellow. During shift transmission, during introducing the doctor to his patient, during the rounds, there is only two words: think yellow. Once they think about to place the medical equipment in the yellow bag, the rate increased from 63% to 88%. The raise from 88% to 100% was doing a simulation session. That there is an access program will let you enter a room, a patient room. This patient room contain a lot of waste. Where to segregate in the regular waste, the black one, or the yellow one, or the red coded one, and that is that gives a lot of knowledge to the staff, and they are able to segregate well. Please next. Okay, this ATP machines. Infection control was entering every patient room, and he just checked if it's cleaned or not cleaned or not cleaned, as a visual audit. When using a machine such the ATP machine is a machine, you use the swab, you swap a surface, and you put the swab in the machine, you activate it, 15 seconds, it will give you a result. This result will be expressed in RLU, relative light unit, which is a form of ATP detection machine. Every organic material present on every surface contain a form of life, which is ATP. This machine is able to detect such organic material. We are searching that more. We are searching more and being objective more and finding is this surface is cleaned or not. Visually, it's cleaned, but microbiological, it's not cleaned. This form of ATP machines or this kind of machines create a challenge for the staff in order to clean well their room. I will give you, for example, medical surgical first floor. I will read the table, just one or two rows. Food table, it's caution. The result was 20 RLU. The results need to be between the lower and upper limit, between 10 to 30. Okay, so it's caution. To be perfect, it's well cleaned, it should be 10 or less, a relative light unit. If it's 30, it will be above 30. So here, it creates a competition among the nursing staff. And they are not focusing on just, they are seeing the things that, they are just clean. No need, just apply a simple disinfectant and clean it. You must respect the contact time. You must respect the friction methods. If you drop them, if you drop both of them, the ATP machine will give a high positivity rate, which reflects that you didn't clean the room well. So this form of ATP machines gives the staff a feedback. By the way, this ATP machines is linked to an email system. Once you have the results in the machine and connected to the computer, all the results will be directed to the emails of the individuals. Okay, next, please. Okay, this is another type of a picture showing how the ATP is doing in the first one. Another one in the picture, the nurses is trying to picture something with their phone. This is a QR coding. I will tell you a little bit about it. QR coding now, if you just use your camera in front of this QR code, this will open a PDF file showing the high-touch surfaces that need to be cleaned. Also, it will direct you to other infection control policies and procedures, but in a simple way. The use of QR code as a new technology let the staff know that they don't have to sit in front of the table and see the policy on procedure and read them in details. No, they are using their smartphones